Good evening, and we are going to the second episode of our Diabetes Crossroads. It's an RSSDI Kerala chapter practice changing update series. And today we'll be discussing about type 2 diabetes, evolving pathophysiology and practice implications. So we will be having the sessions very soon, and I hand over the session to Dr. Prashant and Dr. Suresh to initiate the proceedings.
Yeah. Okay. Yeah. Dear friends, today, as Dr. Chandni Madam has said, we are organizing the second episode of RSSDI Kerala State Chapter initiated Diabetes Crossroads, which is a practice-changing update series. And we are going to discuss the evolving information on the pathophysiology of type 2 diabetes and its practice implications as well. Whether the evolution has adequately supplanted the gaps in the therapeutic requirements, whether the newer and changing information has adequately provided the needed thrust and impetus to the development of newer treatment modalities, whether the latest pathophysiology oriented drug development has had any expected impact on the therapeutic outcome, and a lot more details are going to be discussed here today. We have a speaker and 4 panelists for enlightening and enriching our knowledge. Dr. Prashant Shankar, MD, MRCP from London and FRC from Edinburgh is the star speaker of the day. He is the head of Internal Medicine and Diabetes Department at MGM Muthoot Hospitals at Pathanamthitta since 2011. And he has presented original research work at around ADA, IDF conferences and has around 14 research publications to his credit, and has already delivered more than 200 lectures at various academic meetings. And more than all these, he is the governing council member in charge of this particular Diabetes Crossroads series at RSSDI Kerala State Chapter. And he's also in charge of the YouTube channels that we have started. And like other panelists are Professor Dr. Balakrishnan Valiot, Dr. Srinath Bhatt, Dr. Preeti Bhama, Dr. Jayalakshmi Krupp, and who all are going to be duly introduced later. And I thank you all for giving this opportunity, and I hand over the mic to Dr. Prashant for taking over and proceeding with the CME, the talk. Thank you, Prashant. Please take over.
Thank you, Suresh sir, and thank you, Chandni Madam. So we are a bit late, so I will start without much of an introduction. So as Suresh sir has rightly described the topic, a lot of things have changed in the management of diabetes over the last 2 to 3 decades. So I'll be just brushing through what has happened in the management of, in the pathophysiology of diabetes and how it has changed and how it has impacted the way guidelines have been formed. So, and finally, at the end, we will see how whether we have adopted to these new changes. So this will be the agenda for tonight, the ever-changing phase of diabetes therapy, from the triumvirate to the treacherous and beyond, from insulin resistance to beta cell failure, from apoptosis to dedifferentiation, from the glucocentric to the cardiorenal and cardiorenal centric view, and a couple of slides on the novel subtypes which have generated a lot of new interest. And finally, the most important thing, after learning all these things, we have to see whether we are able to make it into the real practice and benefit the patients. So this was the ADA-ESD algorithm when I completed my MBBS. So it was very easy to manage diabetes at that time. We had only 3 drugs and insulin. And learning diabetes was very simple because it was as simple as this. When I passed my MD in 2011, the situation changed. We had the incretin-based drugs which were there in the market by that time. The algorithm became complicated. We had the DPP-4 inhibitors and the GLP receptor agonist. And in 2016, we had the entry of the superstar of current era, that is the SGLT2 inhibitor. The graph or the picture became broader and it became more complicated. In 2019, the ADA and EASD changed the algorithm altogether. Now we have individualized algorithms based on the risk factors like the ACVD and cardiovascular and heart failure risk, renal risk, hypoglycemia, and also the cause factor. And this is the latest one in 2022, which again re-emphasizes the importance of individualization of therapy and choosing the therapy based on the comprehensive patient profile and the individual risk factors. And probably this is one drug which we had a launch yesterday. This might peep into the algorithm in the coming days. This is something different from all the drugs which we have in all the other drugs. The oral GLP-1 receptor agonist is available, and this might get an entry into this picture in the coming years. So I would brief you with a couple of cases which came to my clinic in the last 2 weeks after this meeting had been planned. So this is a 75-year-old male, type 2 diabetes of 15 years, came for a medical checkup after a gap of 3 years after the COVID and all those things. He was on metformin 500 milligram, 2 tablets 3 times daily, glimepiride 1 milligram, 2 tablets 3 times daily, atorvastatin 10 milligram. He was asymptomatic. He just came for a review because he thought he hadn't seen the doctor for many 3 or 4 years. So just came for a review. His HbA1c was good. Creatinine was normal. He had mild peripheral neuropathy. Good functional status. He was able to drive his car by his own. And he just came for a review. He had mild hypoglycemic symptoms. That is one of the reasons why he came to the clinic. So this is one patient. And the second patient who came yesterday to the OP, 42-year-old male, detected diabetic 2 weeks ago. And he was symptomatic with all the symptoms of hypoglycemia, fasting of 250 and postprandial sugars more than 400, HbA1c of more than 13.9, and LDL of 154, family history of ACVD in his father. And he has a sedentary job in the Middle East, and he came for a period of 2 weeks, and suddenly he was detected to have diabetes and wanted some rapid control. He had gone to a primary care practitioner where again he was started on metformin 500 BD. So we will come to the discussion of the cases at the end, so you can have this in your mind. So this is where it all started in 1987 at the Lilly lecture, when Ralph DeFronzo came up with the triumvirate concept of diabetes pathophysiology. That this is what he quoted. It is obvious that defects at the level of the cell, muscle, or liver beta cell, muscle, or liver can lead to the development of glucose intolerance and or diabetes mellitus. And at that time, it was not clear to define whether a given diabetic individual, what is the primary defect, whether it is insulin resistance or impaired insulin secretion. So this led to the triumvirate concept of the diabetes pathophysiology, which most of us are following even now. And in 2009, at the Banting lecture, again, DeFronzo changed the picture from the triumvirate concept to the ominous octet, which again, we are all familiar with. So this is the ominous octet, which we all know. And this was the consensus by DeFronzo. Multiple drugs should be used in combination, and the treatment should be based on reversal of all the non-pathogenic abnormalities, and it should be started early and aggressively so that the beta cell failure is well established. Before the beta cell failure is well established. And the classical trio, which is suggested by DeFronzo, was a combination of thiazolidine, metformin, and exenatide, GLP-1 receptor agonist. And sulfonylureas were not recommended by him. Again, something which raised many eyebrows, especially in the Asian doctors. So this was DeFronzo's magical combo to control diabetes at an early stage. Then there was the concept of beta cell failure or the beta cell as the final common denominator of diabetes, which led to the expansion of the pathophysiological changes in diabetes with beta cell at its center, and which led to the egregious 11. So here again, you can see the primary endpoint is the pancreatic beta cell, and lot of factors affecting the pancreatic beta cell, like the incretin effect, the alpha cell defect, the kidneys, the stomach, the immune regulation, the colon biome, and again the liver, muscle, and adipose tissue, and even the brain. And there was a description of different agents which could act at these different points to control the pathophysiology or control diabetes. This is something which came in between the the importance of beta cell, which there's an appraisal of the importance of beta cell. The beta-centric model recognizes that the final common denominator is the dysfunctional beta cell. It could be the function which is compromised, or it could be the loss of mass which is compromised. And the ideal treatment regimens should not be potentially detrimental to the long-term integrity of beta cell. And during that time, Indians also had their own share. The dirty dozen of diabetes was proposed by Sanjay Kalra and team. And you can see along to the ominous octet, he added catecholamines, vitamin D, renin, angiotensin system, and testosterone. And then came the treacherous 13, where he added the importance of iron as a pathogenetic factor in the development of beta cell apoptosis and development of diabetes. Then it went on to the formative 15 and the forbidden 14s. These are all very less prominent things, but just for the sake of completion, I have included all these things. Just we should know that a lot of things have, there are a lot of things which have undergone change during this period. One of the important parts of the egregious 11 was the adipose tissue, obesity, and inflammation. Couple of slides on that. Obesity is associated with both insulin resistance and adipose tissue inflammation in patients with in humans and animal models, and the causality has been controversial. You know that there are multiple factors which cause the obesity, and multiple diseases which obesity causes. And the adipose tissue inflammation, again, it leads to a lot of things like systemic inflammation, adipocyte insulin resistance, decreased adiponectin, and all these lead to increased ectopic fat and increased skeletal muscle fat and liver insulin resistance, which again leads to the systemic insulin resistance. So this is another mechanism which could play a role in the pathogenesis of type 2 diabetes. Talking about the adipocytes, again, there was a concept of metabolically healthy obesity and how it is different from the others. So the basic thing which came out was that there are two types of changes in the adipocyte which is occurring. One is the hyperplasia and it is the hypertrophy. So the hyperplasia, usually it has got a better insulin sensitivity and it is less inflamed, while the hypertrophy of adipocytes is associated with immune cell infiltration, pro-inflammatory pathways, and increased insulin resistance. So that was the reason for the difference in the metabolically healthy obesity and the metabolically unhealthy obesity, which we have described. Then coming to the discussion of adiposity and ectopic fat. This is one person who has turned around the lifestyle management of diabetes, Roy Taylor, and this was his famous quote. So if you can't fit into the genes you wore at the age of 21, you might be at risk of diabetes. So this was his famous quote, which was seen in almost all the papers at that time. So this was the twin cycle hypothesis by Roy Taylor and his team, where he demonstrated that there is an increase in the hepatic fat and it translates to an increase in the pancreatic fat. And in patients who get substantial weight loss, there will be a decrease in the hepatic fat. It will improve the insulin action and normalize the blood sugars. And it will consequently lead to the decrease in the pancreatic fat and normalize the insulin response to eating. So that is one of the important reasons for the reversal of type 2 diabetes, or at least what we term as the remission of type 2 diabetes. So this is the twin cycle hypothesis. And this is what happens with remission. The liver fat and the pancreatic fat reduces, and it improves the beta cell function. And again, that leads to the concept why even lean patients, especially the Asian patients who are lean, are also developing are also developing fatty liver and developing diabetes. So in a lean individual, the amount of extra adipose tissue or the ectopic fat accumulation required to develop diabetes is much less than an obese patient to develop diabetes. So if you are 2 kg in excess, from 48 you get to 50, you will be at risk of getting diabetes. But if you are 85 or 88, you will have to climb up to maybe 94 or 100 to become diabetes. So that's why lean people with the predisposition are also at risk of getting diabetes. The counterpoint study was one of the earliest study where people were given a liquid calorie diet and people with type 2 diabetes achieved an average of 15 kg weight loss. And this was one of the earliest study which showed that reversal with weight loss can improve the beta cell function. Then came the big trial, the direct trial, which was an RCT, which was done in primary care. That is again the importance of this trial. RCT, which was done in primary care, almost 30% of those participants had a weight loss of 14.5 kg. And the direct trial showed that people in remission could return to normal maximal insulin secretion rates. That is, the beta cell can come back to normal if they maintain their weight after the rapid weight loss. That direct trial was done in obese patients. Now, Roy Taylor again went on with the retune study where he took non-obese patients with a BMI less than 27. Again, this was a small study with 12 patients. Again, this study showed that diabetes is reversible, or at least it can be brought to remission, and HbA1c with an HbA1c of less than 6.5 if there is a substantial weight loss. And even in this study, you can see that when the patients were put on a low-calorie diet, the plasma insulin dropped, their HbA1c dropped, the hepatic and the pancreatic fat dropped compared to the control group. And 8 out of the 12 participants achieved diabetes remission. So that led to the concept of personal fat threshold. So it's not a global fat threshold. Every individual has got its own fat threshold. And if he gets a fat accumulation beyond that threshold, he is destined to develop diabetes, along with multiple other factors like the genetic and the epigenetic factors and the other lifestyle factors. So this brought about a change in the pathophysiology of diabetes. That is, the complete return to normal function of beta cells is remarkable. We were talking about the apoptosis of beta cell, but we now are talking about the de-differentiation which is happening and not the apoptosis. So excess fat exposure causes beta cells to de-differentiate, losing their ability to secrete insulin. And the return of normal by a large people with weight loss shows that the beta cell is the function of beta cell is reversible, and some individuals may remain in remission for many years provided the weight is not regained. And this is why all individuals with diabetes may not go into remission, even though the hepatic and pancreatic fat has been reduced. So it depends on the capacity of the beta cells for recovery, and the capacity is maximum for patients who are having a shorter duration of diabetes, the lower HbA1c at diagnosis, and younger age. So as all these parameters worsen, the chances of recovery are less. So that means that you can select patients if you want to put somebody into a remission, or if you're trying for an intensive weight loss program, it helps in the patient selection. So that led the ADA to put out the criteria for remission of diabetes for the first time ever in the history of diabetes management. This came in August 30, 2021. That remission of diabetes was defined as return of HbA1c to less than 6.5 that occurs spontaneously or following an intervention and persists for at least 3 months in the absence of usual glucose lowering pharmacotherapy. So that is the definition. Now we go on to the other part, the glucocentric concept, which was there. The UKPDS study, I need not explain in detail on the UKPDS, which showed that 1% reduction of HbA1c led to significant reduction in the microvascular complications, and also a small reduction in the all-cause mortality and the myocardial infarction, though the macrovascular complications were not reduced significantly. The aggressive trials like the ACCORD, ADVANCE, and VADT, even though they showed that the microvascular complications have come down, they did not last long, because there was increased mortality on one side because of the aggressive or the extra aggressive glycemic control. And one of the reasons postulated is the increased incidence of hypoglycemia, because the medicines used at that time were mainly metformin, sulfonylurea, and insulin. So both these studies, even though they showed that microvascular complications came down, they did not show that the macrovascular complications can be improved with the glycemic control. Then came the diabetes and aging study, where again the importance of early control of diabetes was emphasized. You can see 4 graphs. You can see the low stable HbA1c trajectory at the bottom, and the other different trajectories And you can see that the low stable, or the blue line, has got the lowest risk compared to all the other lines, which has got higher risk. The stable low HbA1c values may confer additional benefit and beyond controlling the modifiable cardiovascular risk factor. That's why we see that some people with long-standing diabetes do not develop complications. Some people with the same duration of diabetes develop complications. Probably they had a high decreasing early trajectory with highest initial HbA1c levels of more than 10 at 11 at the time of diagnosis, like the patient number 2, which I showed today. He might be at increased risk of diabetes, but the patient number 1, probably he is having a low stable trajectory. 15 years, he's doing well at the age of 75. So a marker of long period of undiagnosed diabetes resulting in more complete beta cell secretory dysfunction at diagnosis and greater risk of mortality. And these patients may not be suitable for a reversal also, for a remission also. So what the legacy effect, the diabetes and aging study showed that what the UKPDS showed in the randomized control trial, it was replicated in the real world study. So the association of glycemic control has been shown in the RCTs, but whether the metabolic memory persists in the real world was proven by the diabetes and aging study. So what did it show? HbA1c levels of more than 6.5 for the first year of diagnosis was associated with greater risk of future diabetes complications. And HbA1c levels of more than 7 for the first year of diagnosis was associated with increased risk of future mortality. And increasing periods of exposure to HbA1c more than 8 were associated with an increased risk of microvascular events and mortality. So it showed that legacy effect exists outside the trial populations. And what it means is that as early as possible, within the fourth year itself, we have to get the blood sugar controlled to less than 7 in the selected patients without putting the patient into hypoglycemia. So this is pre-diabetes and early type 2 diabetes. This is the new concept of management of diabetes from the older concept, where the game starts in the pre-diabetic period itself. The changes may start occurring in the pre-diabetic period itself. And by the time the patient develops the advanced type 2 diabetes, all the complications would have set in. And we know the cardiocentric pathways, the cardiorenal centric pathways, which have been described of late. You can see that there is a good interaction between the heart and the kidneys, and they both play an important role in the progression of the pathogenesis of diabetes and the progression of the complications. So then came the cardiovascular outcome trials. It all started when the rosiglitazone complications arise, when it was seen that rosiglitazone increased the heart failure, chances of heart failure. It was made mandatory that all new drugs undergo cardiovascular trials to show the safety. It was started as a safety trial, but it changed out to be a cardiovascular benefit trial. So you can see these were the initial trials with the initial drugs. You can see that almost all the gliptins were shown to be cardiovascular safe. There were some concerns with heart failure with saxagliptin. Insulin, like even the newer insulins, have undergone a cardiovascular trial, which has shown their safety. Metformin has it was not undergone a cardiovascular trial, but it has shown its efficacy in the UKPDS and all the other studies. Coming to the SGLT2 inhibitors, the EMPIREX study showed that SGLT2 inhibitors are not only cardiovascular safe, but they have reduction in the 3-point MACE, cardiovascular death and heart failure hospitalization, and all-cause mortality, and also the renal outcome. EMPIREX was the first CV outcome trial to show a positive benefit with an anti-diabetic agent in reduction of cardiovascular death. Then came a series of positive trials with SGLT2 inhibitors, all the studies showing virtually the same results with slight differences based on the patient, the population selected. And the GLP-1 receptor agonist, again, they showed that the atherosclerotic cardiovascular risk reduced, and the renal outcomes were also improved to some extent, but on a slower basis compared to the SGLT2 inhibitors. So we now have a huge list of drugs which, when rightly given to the patients at the right time, can improve not only the glycemic control, but along with that, they can improve the cardiovascular outcome and the renal outcomes without causing hypoglycemia. Finally, at the end, we have the verified trial, which was published a couple of years ago, which looked at the importance of early combination therapy in patients with diabetes. All these things started with the different source concept, but the verified trial was the first trial which looked at the aggressive early control, even in patients with HbA1c in the range of 6.5 to 7. And the verified used vildagliptin along with metformin, and it showed that early combination treatment halved the risk for time to initial treatment failure versus monotherapy strategy. And the median time to failure was 3 years with initial monotherapy strategy and compared to 5 years with the combination strategy. So you get an extra 2 to 3 years so that the patient is maintained at a good glycemic control. We know that it's the initial years which is very important in preventing the long-term complications. And all patients, the secondary treatment was reduced by 26%. And this study also had an exploratory outcome for cardiovascular endpoints that also showed some improvement. Though this study had patients with very low risk of low cardiovascular risk enrolled because it included patients with very recent onset of diabetes. Finally, this is something which has generated a lot of interest in the last couple of years, the novel subtypes of diabetes based on the various markers like HbA1c, the insulin resistance markers, and the BMI and age. The whole concept of type 1 and type 2 diabetes was changed, and new classification was proposed, like the SAID, the SIDD, and SIRD. It was based on the Swedish cohort, the severe insulin resistant diabetes, the mild obese related diabetes, and the MARD, or the mild age related diabetes. So this was done on the Western population. And this was again a very interesting thing. So what Dr. Mohan and his team did was that they tried to apply this to the Indian population, and initially they found it difficult to apply the same parameters to the Indian population. And in their own studies, they screened around 20,000 patients with type 2 diabetes, and so they developed another cluster based on the initial the ANDIS cluster. And these are the Indian clusters which have been described of late. That is the severe insulin deficient diabetes, the insulin resistant obese diabetes, the combined insulin resistant and deficient diabetes, and the MARD, or the mild age related diabetes. So these are the Indian clusters which are described by the team of Dr. Mohan. And what is the importance of this clustering is that it also helps us to predict the development of complication. It was seen that some groups had increased risk of developing retinopathy like the SIDD and the CIRDD, while some groups had increased predisposition for the development of nephropathy and CKD. And you can see all these can be, you can explore all these details from this study. So this is what I had to describe in the last 20 minutes. I think I have completed the discussion in time. So with this, I think we will proceed to the panel discussion, which is the most important part. I will just introduce the panelists to the audience, and then I will stop sharing the slides. We have 4 panelists who have been working at 4 different sectors with 4 different levels of experience. So that's what we wanted for this meeting. We wanted to share the experience and the knowledge at all different levels, not only at the specialist level, but all levels of diabetes. So first and foremost, it's my honor to introduce Dr. Balakrishnan Velliyot. Is a very well-known figure in the field of internal medicine and diabetes in the country. He is currently the professor of medicine at Government Medical College, Kannur. He is also the head for the Center of Medical Research and Non-Communicable Diseases, and is a former Dean Faculty of Modern Medicine at Kannur University. He is also a research guide for medicine at Puhas and Kannur University. He has got almost 3 decades of teaching experience and 35 research papers, and contributed articles in journals and more than 100 presentations. The second speaker is Dr. Preeti Pama, who is currently practicing as a physician at Kayankulam, St. Thomas Mission Hospital, Kayankulam, and she had her MD from Government Stanley Medical College Hospital, and she is also a speaker and panelist at various diabetology conferences. Her special area of interest is sleep disorders and post-COVID psychological disorders. The next panelist is Dr. Srinath Bhatt. I think I lost the slide in between. Dr. Srinath Bhatt is the physician at Kanyanad, and he's a very senior physician who has got more than 3 decades of experience. He has his degree in diabetology from Australia, and is our second panelist. Finally, it's Dr. Jayalakshmi, who he's currently working as a senior medical officer in Fortress Hospital, Cochin, and he is our fourth panelist, and he also has a master in health science and diabetology from Annamalai University. So I hereby conclude my slides and I open up the discussion for the panelists.
Thank you.
Sir, I missed your slide in between. I made it ready in between. Slide. So I will start the discussion with Dr. Balakrishnan, sir. Sir, the first question is the importance of initial monotherapy or initial aggressive treatment of diabetes. So, how do you initiate treatment of diabetes in a newly diagnosed patient? You start with a monotherapy with metformin only, or you start with an initial combination therapy?
Okay, good evening all. I think I am audible.
Yes, sir.
Yes. And it's a pleasure to be a part of this diabetic Crossroad 2 program organized by the Kerala chapter of RSSDI. At the outset, let me thank the whisperers, the Chandini, Suresh Kumar, and the dynamic team member and the organizer of this program, Dr. Prashant Shankar. And also, I would like to wish our co-panelists, Dr. Srinath Bhatt, Dr. Jayalakshmi, and Dr. Preeta Bama. It is a pleasure to share this platform and to be platform with very senior participants who are also been listening to our presentation. Together with our panelists and presenter Dr. Prashant Shankar, we will try best to convince what is the present scenario of diabetes management. So the first question, that is a very pertinent question. And, at the outset, what I want to tell you that we have got a large number, lots of guidelines, international guidelines, how to initiate the treatment, how to step up the treatment, and how to take care of the patient. But I want to stress the point that Indian diabetic are entirely different, or they have got a different profile when compared to the Western population. To the extent that we develop diabetes at an younger age, nearly around 10 or 20 decades in certain studies. And our population, especially the Asian phenotype and the Indian diabetes patient, has got a lot of comorbidity at the outset of starting, or even when the patient is having recently diagnosed diabetes mellitus. And 40% of our patient with a newly detected diabetes has got an associated hypertension. We have got a more of a truncal obesity, and we have got and in Kerala, we have got the highest number of young myocardial infarction patients, highest number of hypertensive patients, and lot of obesity also being the major issue in our state. So we cannot exactly follow the guidance which has been suggested by either ADA or other guidelines which is applicable to the Western population. To some extent, it may be applicable to us also. So what actually, when I came across a newly detected diabetes patient, I take a detailed history, I go for a clinical examination as we expected. And I look whether the patient is this particular category of a diabetic patient is a symptomatic or asymptomatic. Many of the newly detected diabetic patient is asymptomatic.
Sir, you are muted, sir. Yeah.
Okay, what I usually do in a newly detected patient is to see whether the patient is symptomatic or asymptomatic. And many of the newly detected diabetes patients, they came to know that the patient is having a hyperglycemia or a diabetic on a casual examination or as a medical examination or when they go for another examination. So in all patients, newly detected patients, I order for a fasting blood sugar or a postmortem blood sugar and A1C, a creatine, and the lipid profile. And if the A1C comes in between the 6.5 and 7, and if the patient is only not having any symptoms, I follow the guidelines that we go for a lifestyle intervention and we advise the metformin and all thing. Unlike the 3 months follow-up and other things and monitoring the HbA1c, I go for a frequent monitoring of this patient, because if we are going by the guidelines and asking the patient to come back after 3 months with an A1C, probably they will feel that it is not a major issue. And in between, if they develop a complication, we may not be able to follow. So we step up the treatment from the lifestyle modification and metformin to another modalities of treatment if it is needed in this category of patient. If the patient is symptomatic, and he has got a comorbidity like hypertension, myocardial infarction, ACS, and other things, and the A1C is more than 7 and in between 8 or 8.5, I am going for a little more aggressive in managing this patient. And what I actually do is I go for a dual therapy of this patient, either a combination of a metformin or a sulfonylurea, either a low dose or with a usual dose, and then initiate the treatment and ask the patient to come in 2 weeks and again monitor, and I step up the dose with this dual therapy. And the patient is too symptomatic, there is a negative calorie value, and the patient has got renal impairment or an established acute coronary syndrome, etc. I think that this patient is the ideal patient where we have to start an insulin, either as an inpatient or in the clinical, from the clinics or whatever it is. So I usually go for this categories of the patient in initiating the treatment, unlike the and do not blindly follow the guidelines of international guidelines.
Thank you, sir. I think this is very important that you have to individualize based on the patient profile in your place. So I would carry on the question to Srinath sir for a quick answer to that, whether you follow the same or is there anything different?
Right. I think it's all, I think I'm audible, Prashant.
Yeah, yes, very much.
Outside, I thank our dynamic office bearers of RSSDI Kerala, Dr. Suresh, Chandni. Of course, Prashant is a good friend of mine. All the time I do see him either in the Facebook or otherwise. I think he's one of those characters who definitely we RSSDI definitely can bank upon for our future activities. Thank you, all of you. In fact, this particular question, actually what happens is we as practitioners, even like I'm in a very remote area of Kerala, what is important is, first of all, we have to have some development, rather we have to develop some fascination in treating the diabetic patients. We should not treat them as like any other patient. We have to spend a lot of time with them. I personally feel from the day one, like I started in 89, when a patient of diabetes comes, I just get rather in a different mode. The initial looking at their history, whether they are symptomatic or not symptomatic, they come with some particular report, then I work them up. I work them up when I say the day one itself, I would like to definitely ask for a HbA1c. That's a gold standard those days. Now, of course, it's slightly changed and we are now talking about TIR, etc. Whatever said and done, we still in periphery, we do have do HbA1c by HPLC method. In our lab, we do use biorad missions. I think that's one of the most standard missions all of us should actually focus. So it should be a certified laboratory wherein we can have a dependable HbA1c value. That is one. That will only goes to say that how severe is your patient's glycemic status is. And at the same time, just to know what exactly is the other background comorbidity he has, I would like to rather have a lipid profile. And then, of course, as soon as they enter to us, we will have all the height and weight and BMI and all the things. We'll have additional data, which category our patient is rather going. So once we have all these lipid profile, renal profile, and I also do most of these people baseline SGPT, SGOT, just to know the hepatocellular dysfunction, and also a TSH. A thyroid profile also I do in most of my patients when they come on for the day one. So once I have a overall picture of my patient, his glycemic status, and what other comorbid condition he has, I just start off the treatment. If he's an obese patient, I will rather go for a metformin. And if he comes with the history of, he's already an insulinopenic patient. So like when he enters my chamber, I do see a emaciated patient with a very well above fasting sugar 250. I presume that his beta cells have almost exhausted. In such a case, patients, I rather tell him it is rather I don't want you to look like a patient with a thin down. So if possible, you start off depending on the features of insulin resistance and other things. I rather add a small dose of pioglitazone or insulin. So metformin I don't give to such patients who come on the day one also. If they are insulinopenic or if they are emaciated already, if they don't have a muscle mass, I don't advise that. Of course, what is standardized is in all our patients is we definitely advise a strict dieting. We have a diabetic educator. We have a registered dietitian with us now as a team. And definite advice regarding exercise and other things are given as per the ADA. This thing I do always tell them that that's very mandatory, because it is almost like a 4 legs of a table, wherein the table will not be stabilized without all these added treatment options. So we have a OAD segment with or without insulin, depending on the type of patients, how they present. Then we have a good dietetic advice consultations we do. And we also advise them exercise and other things. And I also don't forget to tell them when exactly they have to, how exactly they have to monitor all their comorbid conditions. Like lipids, I tell them at least once in 6 months. Regarding ACR, albumin creatinine ratio, I tell them every 6 months you can do it. Even HbA1c, even though ideal it is every 3 months. Even, of course, depending on the situation, sometimes I tell them at least biannually you can do it. And once a year, I always tell them, have a good eye evaluation and a renal profile and a VPT. I don't forget them to do even a VPT assessment, just to know, because most of the time when they come to us, we do not know when is actual diabetic process has started. It may be they must have gone through a big time of pre-diabetes and they have landed up with us. So I would like to rather have a total assessment of this kind, and then just to know just to have an impact, not just a glycemic control, even other comorbid conditions you manage.
Thank you, sir. I will pass on to Dr. Preeti. Dr. Preeti, your small comments on the same. You still start with metformin, or you still you have patients being started with a combination of metformin plus gliptin, or a metformin plus an SGLT2 inhibitor? Or still you are starting with the metformin plus sulfonylurea? What is your preferred combination?
First of all, let me congratulate Dr. Prashant for such a wonderful and crisp presentation on a lot of topic. I learned a lot from your presentation, the new pathophysiology of diabetes. So as I will go with Dr. Srinath Bhatt sir. Whatever he told, that is what I usually put into practice. When a patient comes to your OP, he comes to your room, the first physical appearance is what guides your treatment probably. Can you hear me?
Yeah.
The first physical appearance is what guides your treatment. So if a patient comes to me and his blood sugars are, I would say I start the treatment a little early. I don't usually allow my patients for a trial of probably I give for 1 or 2 months, but not later than that. And my thresholds are a little low for a fasting blood sugar of probably 130 and a postprandial sugars of probably 200. I will start with metformin. And the thing is that when you start with a lower blood sugar level and then advise them to go for a lifestyle modification and weight loss regimen, they will probably be more help, and that will be more helpful, and the patient will be like it will lure them to go for a weight loss, because they will all invariably want to remove the oral hypoglycemic agent. So that helps, like it is giving a something for the patient to work upon, giving a goal. So that I lure them by saying that probably if you lose weight of 10 kilograms in the next 6 months, I'll remove your drug. So that the patient will be more, he'll try to lose weight. And I give a modified diet also. I usually explain all the patients with a low calorie, low carbohydrate diet. In patients who have a good IQ in understanding what low calorie diet means. And when you put such patients who are not, who have a good IQ, and I probably give for 2 or 3 months and they are able to sustain that low calorie diet, then we can always remove the oral hypoglycemic agent. And my first choice will always be metformin. And patients who have a higher blood sugar level, probably I go with the DPP-4 and a metformin combination. But patients who are obese, like patients who have a BMI of above 30, I usually start nowadays with SGLT and metformin combination also. And that also helps in weight loss. My aim is always to achieve a weight loss and give a low calorie diet. So many of my patients I am able to wean off from OHA or probably insulin in the first place after probably 5 or 6 months, if they are able to achieve the sufficient weight loss. So that will be my aim. And regarding comorbidities, I always work up for what Sir told, lipid profile, baseline SGOT-PT to look for liver dysfunction. And if the patient has a liver dysfunction, I find pioglitazone very useful in bringing down the level of inflammation, and the transaminases rapidly become normal when the patient is put on a pioglitazone and metformin combination. So my threshold, I would say, is low for starting the patients on OHA, because the initial control of diabetes decides a lot. As Prashant was telling, the initial control of diabetes decides what the legacy effect. The initial control is a very must to avoid the microvascular and macrovascular complications of diabetes later on in life. If we as physicians procrastinate for a long time, I think we are losing time and we are losing pancreatic cells also.
Thank you, Dr. Preeti, for that crisp answer. And one final look into what happens in the primary care level with Dr. Jayalakshmi. Are you there?
Yeah, I'm there.
Yeah.
Good evening, Prashant. Am I audible?
Yeah, very much, madam.
I'm so sorry, I'm traveling, so I think there might be a cracking up of the signal. So the first thing that I do when a patient comes to my OP, with most of them, at least these days, I don't see much of them coming with the typical symptoms. Okay, so it's an accidental finding that you find them with high sugars. The first thing I do is I tell them if there is a family history of diabetes and all that. I do a complete workup, like the fasting, glucose, the postprandial lipid profile, renal function test, all the whole armamentarium of the investigation. Because since I work in a public sector, the cost is not a factor. The treatment as well as the investigations come free of cost. So patients are also agreeable to do that. Then I do a diet recall. I ask them what they had the previous day, and I just try to titrate them and ask them to cut short on the carbohydrates and add more veggies and maybe fish or anything, avoid red meat. I just tell them how to go about their diet profile for the next 1 month. And most often, yes, I start them on metformin. That is almost always the first drug of choice. I do not give much of sulfonylureas to elderly patients. The sulfonylurea I prefer mostly is glycoside extended release. And young people, of course, I like them to put it as a second choice. So metformin, I start them on metformin and ask them to come and repeat the blood test of fasting and PPBS. And the next time they come, the first day we don't have HbA1c at the hospital, so they'd have to give blood and we send it outside. So I ask them to review after 2 or 3 weeks. And I ask them again how their diet is. And most often, most of the patients are quite willing. And since they don't have the burden of the cost, I don't think there is much problem. And we do not have SGLT2 receptor inhibitors in our hospital. So we have to manage with what we have. We have DPP-4s. And so that's just about it in our hospital.
Thank you, madam. Again, so that from 4 different aspects and 4 different parts of the state, we are getting, there are some differences, but there are a lot of things in common when it comes to the management of diabetes. So The next question, I would like to get a very short and crisp answer from Balakrishnan Velliyot sir on whether your practice has changed from after 2015, after all the cardiovascular outcome trials have come. Are you going more for an SGLT2 inhibitor or a GLP-1 receptor agonist? Are you in that line, or you are still going with the old therapy? That's why I specifically put that case number one. The case number one, which I put, the patient had been on metformin and sulfonylurea for almost 15 years. The patient is doing well. He has passed almost the time to develop the complications. That means that in selected patients, even the older drugs work. But in other set of patients, you might require agents which improve the cardiovascular profile. So what's your opinion on that? Yeah, please unmute, sir.
So for several decades, when I was a student and when I became a teacher also, so I was taught that the diabetes is the disease of pancreas. And for several years, I also taught that the main issue in the diabetes is with the dysfunction of the pancreas. But the dramatic change in our concept after the default theory of omnis object, and as Prashant well elucidated, now we are going to get all the 14 components or 13, the treacherous 13 or the 14 component. Now there is a paradigm shift in our concept and our understanding of the diabetes. And since 2005, we have got a flurry of pharmacological agents come to the markets. And we have got a large number of trials. I think you have brought out most of the trials. And when the SGLT, gliptin, and the GLP and LOS were all introduced, we were convinced by the MR canvas or the DAPA, the declare TIMI, or with the other DAPA CKD, and all the trials convinced that there is a marked cardiovascular mortality benefit, and all-cause mortality was decreased. So since then, we also understood about this benefit, and I gradually shifted inside. But still, I think there's nearly 50% of the patient still getting that glucose-centric approach, and we are trying to decrease it. But if we came across a comorbidity in this patient, especially we know that it is an obese patient with a myocardial infarction, congestive cardiac failure, or with the renal failure. Now we started shifting to the newer modalities of treatment. We started adding the SGLT, and but of course, as you know that we several times we follow whether what is the guidelines and what is the outcome, and we are convinced in all cases we add the SGLT. We after the TCOS trial initially during that period, I also convinced that gliptin can be the primary drug which can be given to this patient. Then I started adding the when the trial about the garomelin and the trial, we started adding the linagliptin. Now the primary, when the price, and I have got some reservation adding the SGLT. I'm very price conscious still in our area, and I want the patients to continue some sort of treatment when I started the other test. So till the price reduction has occurred in the SGLT, I was a little reserved in writing, and I used to give the gliptins. Now I'm liberally starting the SGLT in most of the patients who has got a cardiac failure, who has got a renal failure. And of course, I agree that the GLP analog injections and the semaglutide, which has been coming in the market, we are not able to start in all the patients, but very selective and choosy. We started liraglutide injection and other GLP. Otherwise, now we are most of the patient who is having some comorbidity, CKD or cardiac failure or other issue, I add an SGLT inhibitor or a gliptin to the most in this prescription.
Yeah, Dr. Srinath, your views on the same?
I think from the day one, actually, if depending on the how they present it, I always tell them early initiation of insulin is always good. But then most of the people, as in India, you know, Prashant, most of our patients come with around 14 or 15 years of history of diabetes with multiple drugs. But in such a case, all depending on their presenting mode with the comorbid conditions, I do definitely shift. Last 4 or 5 years, definitely things have changed. As Dr. Balakrishnan said, I always I second his opinion, because the cost of SGLT2 inhibitors also have come down now dramatically, almost under 10 now, 8 or 9 rupees. I think definitely it is not a big thing for our patients. even though it is a post-COVID scenario hanging around. But then I never had a problem with my patients who say, this is very costly. So it is all depending on how exactly you convince them and how exactly you make them convince that this particular drug is useful for you. This is how it is going to work. For that, you will have to spend a lot of time. You have to spend a lot of time in that therapeutics. Once you diagnose, 15, 20 minutes, come with the investigation, another 15 or 20 minutes. And then with your team, with your educator around, you just hang around and convince them, and then you start the treatment, because you want them to hang on to the treatment. It is not a day 1 or day 2. We are not imposing the treatment. They have to be convinced. That is how I start. And SGLT2 inhibitors have changed dramatically. In fact, there were days when way back in 89, when I started practicing Kanyangar, there was a small chapter like brittle diabetes or difficult diabetes. Now I do feel that there is nothing like a difficult diabetes. Every diabetes can be handled well, with so much of weapons around, so much of lovely drugs, with excellent pharmacokinetics around, and with the definitely having an impact on the pathophysiological, which Dr. Prashant said. We have so many, 13 or 14. And if you know that background, your particular patient, he belongs to which type of pathophysiology, you use such a lovely drug, since it is available, it's everything, except probably GLP-1 receptor agonist, which I don't use it much because of the natural issues. All other drugs have used it. In fact, I'm an insulin man, to be frank. I do put my patient predominantly initial day itself on a basal insulin along with the OADs, and they are very happy with that. And the moment if I have to upgrade it, now of course I have 2GO, or otherwise I shift on to premixed insulin, either the regular insulins, human insulins, or analog insulins. I do have a huge segment of insulins which they still stick on. I'm convinced out of my last 30 years of experience that those who are on insulin, they have very least complications. Thank you very much.
Thank you, Dr. Srinath. Again, we have a different point of view. That's what we wanted from this meeting. We wanted the expert opinions from different corners, and that would make the meeting a better meeting. And Dr. Preeti, I will just shift from the cardiorenal aspect to another aspect of postprandial hyperglycemia. So what is missing in the ADA-ASD guideline is the postprandial sugars, which we see very commonly in the Asian patients. So we have a drug, an alpha glucosidase inhibitor, which has not still come into the ADA or ASD guidelines, but it is something which is indispensable for the Indian patients, at least our Kerala patients. How commonly do you use alpha glucosidase inhibitors, and how much useful are these drugs to you?
Usually, I don't start straight away with the alpha glucosidase inhibitors. First line treatment is always metformin, and along with that, probably a DPP-4 or SGLT2. But when you see that on subsequent follow-ups, the postprandial blood sugars are not within target range, we usually start with PPG. For PPG control, you start on alpha glucosidase inhibitors. My first choice is always voglibose. I don't use much of acarbose, but I usually use voglibose. And I titrate from 0.2 to 0.3 in subsequent follow-ups. And if I don't get a blood sugar control with that, then I shift to a voglibose repaglinide combination, which is usually available. And usually all my patients who have a postprandial blood sugar rise come to target range with the voglibose repaglinide combination. Usually patients who are intolerant to voglibose, those patients who have probably a bloating or a diarrhea with the voglibose, usually I put on, some patients I have to put them on plain repaglinide also. And such patients also do well with repaglinide alone also. So usually postprandial blood sugar is not much of a problem if you're using voglibose and repaglinide. And in patients who don't get the postprandial control with repaglinide and voglibose combination, usually I add probably a 50-50 mix combination for postprandial control. So usually we are able to, but we see a lot of patients who have postprandial blood sugars, very high postprandial blood sugar, their fasting sugars remain normal, but those patients are in a later stage of diabetes. Early stages, we usually see fasting hyperglycemic fasting hyperglycemia is more common. But as the pathophysiology of diabetes goes on and there is beta cell failure, then postprandial sugars are become high.
Yeah, I think as you rightly said, as the diabetes worsens and the beta cell function deteriorates, we see more of postprandial hyperglycemia, and we have to resort to newer therapies to get the sugar control. More number of drugs has to be added. Next question to Dr. Jayalakshmi. And what are the challenges which you see at the primary care level, especially in newly diagnosed patients? You already said that the investigations may not be available at the right time. You may not be having an HPLC related HPLC technique, HbA1c test, or you may not have all the sophisticated instruments. Are there other constraints which are there at the primary care level?
Yeah, we do have some constraints in the that we do not have any GLP-1 analog, or we do not have a SGLT2 inhibitors in our pharmacy. But there are sometimes when we coax the patient about the benefits, yeah, there are some patients of mine who are willing to buy the medicines. And of course, after taking an SGLT2 inhibitor, we ask them to review with their blood sugar levels. They're very happy. I don't think I have at least one patient who has not been happy with the results after starting a SGLT2 inhibitor. Like the recent drugs that are there in the market, those the ones which have got a cost factor, we do not have the liberty of keeping it in our pharmacy. So yeah. So that is a big problem. Otherwise, I don't think we have much of it. We somehow manage with the insulins, and DPP-4 is there, metformin is there, and we do have Voglibus and
Your voice is breaking.
Hello.
I think, madam, your voice is breaking in between.
Okay.
Yeah.
We do not have the liberty of buying the GLP-1 analogs or SGLT2 for those patients who really need it. The problem is that we
I think we lost Dr. Jayalakshmi. She's having some network issues. So we'll carry on with the next question. Again, Balashnan sir, the next question is to you on the role of reversal or remission of diabetes, which we are talking a lot about.
Yeah.
I have described the various aspects of reversal and remission.
Okay.
How much do you look at that aspect of diabetes when a patient comes to that?
So this is one of the most hot topic in the diabetology. I think I'm audible.
Yeah, yes, sir.
This is one of the most hot topic in medicine and diabetology, and it is one of the most controversial subject in all conferences and meeting. And even there was a split among the experts and the scientific community. Are we talking about the reversal or are we talking about the remission? So what is the definition of remission and what is the definition of reversal? And when you call that patient as completely cured, and this aspect is a very, very controversial issue which we are discussing about. And as you have elicited, the UK PDS has told that after 6 years, when the patient is having, they go for a lot of complications. At the outset itself, when the diagnosis of diabetes occurs, 50% beta cell is dysfunctional. Then it goes for the yearly, and in 5-6 years, it goes for 4 to 5%. And finally, after 15 years, 20 years, you are left with only very minimal functioning beta cells, so that your secretagogue or other drugs may not be useful. And on top of that, all the pathophysiology that you are talking about, the omnis octet and the Touchers 13, and it all stimulate the apoptosis, fibrosis, and so many mediators, ROSL, all that. I'm not going to the details of that. Finally, we were convinced that the beta cell is permanently dysfunctional and the diabetes was not reversible. That was our concept about it after the UK PDS and for several years. Now, after the initial some trial, that is the US diabetes prevention program involving around 5,000 subjects. Later, the Dwakin trial and the Finland trial, and later Indian diabetes prevention program. First, they convinced us that diabetes can be arrested, or the onset of diabetes can be prolonged if we go for a lifestyle intervention. And in those one trial, they tried the lifestyle intervention as well as they tried the metformin, the combination, and the placebo and all. And the outcome was varying from around 38% to 52% in various diabetes prevention trials. So there was some idea about it in our mind that probably we may be able to prolong the onset of diabetes, or probably we may be able to arrest the diabetes at a certain point. From that time, we got the outcome data of the metabolic surgery or the bariatric surgery. And depending upon the procedure, whether you go for a banding or R1X or other things, finally they found out that nearly 92 to 99% of the diabetes completely disappeared in those. I'm not talking about the word the reversal. Even that time there was a remission, and there was the patient the HbA1c has come down, the blood sugar has come down, and they need not take any medication, any lifestyle intervention after the bariatric surgery. So again, it was then noted that so many pathophysiological and neurobiochemical changes brought into the patient after the bariatric surgery, and the insulin resistance has come down, and the hepatic function has come down. And so finally, we were convinced that diabetes can be reversed to some extent. And that is exactly what you talk about. The Roy Taylor's trial of a direct trial has shown that if you reduce the body weight around 10 to 15 kilogram over a period of 10 years, and if you are able to maintain, probably you may be able to reverse the diabetes. But the issue what I want to highlight is that a patient who already has got a severe apoptosis, fibrosis of the pancreas, and amyloid deposit, and not dysfunctional, and already developed a neuropathy, already developed a cardiac issue, and there is structural changes into that patient, and probably the diabetes cannot be reversed in this category of patients. So a diabetes patient who is obese, who has got an A1C elevated at the time and newly detected, and if you go for all this, probably you may be able to reverse this category of patients. And that is what exactly. And on top of that, the study with the thiazolidines, the study with the metformin, then the SGLT and the gliptin and the GLP analogs also found that in animal study model, especially in the DBDB mouse and all, it was found that the beta cell proliferation occurs, more beta cell synthesis occurs in this category of patients, and there is convincing evidence. And I'm not going, because I know that we are running short of time, and if I'm going to extend and talk about this in detail, probably we may not be able to finish. I can tell you one thing. Several times we feel that in the severe droughts, a plant is completely destroyed, the flowers disappeared, and we were convinced that the plant has already disappeared from our garden. But when the rain comes, we see that there is some sprout coming, the flower which we thought it's all destroyed. So there is a natural protection for every human being, every creation of the God, and probably what you talk about the differentiation and FOX1 protein, etc. Probably there is some natural conservation which ensure that your beta cell should come back and do again, probably. And now I convinced that there is high chance that there is a chance for a reversal of diabetes. And the definition, what you told, 3 months, after 3 months, you feel that it is completely remission, etc. That is too short. We cannot tell about anything. But if it, and again, the remission, if a patient who is already individualized, if a patient at the age of 90 years, if the diabetes 80 years completely disappear for 5 years, I think it is a complete reversal of diabetes. And if for a 25-year-old, if the diabetes is not there and it is controlled by all these means, and if we become a 50 years, the diabetes come, I can tell it is a reversal. So there needs some concern and change in our concept of the reversal of diabetes and remission. But I am convinced, and at least I feel that there is high chance that we may be able to revert the diabetic if we go for a consistent lifestyle intervention, see weight and calorie restriction and other things, and we cannot give any hope to the patient who already developed a complication in that category of patients.
Thank you, sir. The important points is that you have to have a good idea of the patient background, and patient selection is very important. You cannot ask a patient who is having diabetes for 15 or 20 years to go in for a remission, it is impossible. But there are selected patients who, if who are detected early and an intervention is started very early, they can go in for a remission. Again, the term is very important. It's not a reversal which we are talking about. What the ADA and what Roy Taylor has said is about remission of diabetes, and there are specific patients who might fit into that. This is again, I put this question because this has again become a big problem, because there are a lot of WhatsApp and social media ads telling that diabetes can be reversed by joining this program, and a lot of patients are being misguided. So suddenly they were on 40 or 80 units of insulin. Suddenly they stop insulin and do all sorts of diet and end up with all the complications. So it's a very relevant thing, which again, it should be discussed in a different session. So one question to Dr. Srinath, but again, a small question, sir. Your take on the classical combination of metformin and sulfonylurea. Is it still there? Does it still have a role, or has it gone out?
No, it is still there. Definitely there. But I for one, who do not use much of glibenclamide, I always tell my junior colleagues or even RMOs and others that this is one of the glibenclamide is a very turbulent drug. You'll have to be very, very cautious in using it. And I tell my patients I don't use it. Then, of course, the other new generation drugs like glyclazide, I use plenty. I have a lot of experience with it. And I am convinced that it is one of the lovely sulfonylureas as adjoint to metformin. Then, of course, nothing to say about glimepiride, especially Carolina study and other studies have come and definitely has given a big push to glimepiride in the market. But I personally feel I do use since 1990. Initially, I was using a lot of glimepiride. Maybe after a decade or so, in the second decade in middle, some first 10 years, then I shift to glyclazide. I always highlight and stress upon the fact that glyclazide is a result-friendly drug. As one of our co-panelists said, who is working in the public sector undertaking, government hospital, definitely I'm convinced in last now 30 years, that is one of the lovely drugs and a very result-friendly drug. You can use it even, even in renal patients to a certain level. Of course, even though glyphosate is always advocated, I use it quite liberally in a huge lot of patients as a combination drug along with the metformin. I think glyclazide is, I always call it as a designer, SU, because it has got its own advantages in the pharmacokinetics. Yeah.
Thank you, sir. Again, the point is well taken, sir. I think the other drugs have given us multiple options to individualize on the patient. It doesn't take away the importance of sulfonylureas. Probably.
Small thing, Prashant.
Yeah.
Regarding glimepiride, I always tell my people that glimepiride, you be cautious while using above 70s. I have at least 2 or 3 patients who, with the hypo coming with glimepiride, had to stay in the hospital for at least 96 hours. You'll be surprised because glimepiride, once it induces hypoglycemia, very difficult to reverse it. That way, I think glyclazide is anytime has scores over the glimepiride.
Thank you, sir. Again, I think we should all be cautious when starting sulfonylureas. You have to start at the lowest dose and slowly up titrate so that the patient doesn't go in for a hypoglycemia. And as you rightly said, glyclazide has got a little bit edge over glimepiride, especially the modified release glyclazide is a better option compared to glimepiride. And in my practice also, that is what I do. I usually start with a 30 milligram glyclazide or even a 0.5 milligram of glimepiride sometimes does well. It helps to manage the blood sugars without causing much of hypoglycemia to the patients. So we will skip to the next question. Dr. Preeti, again, we have spoken about this in the previous questions. The aggressive level of glycemic control. Do you have the same slab for all? You target an HbA1c of 7 for all, or you relax the HbA1c for 6 point of the HbA1c for elderly patients?
No, I am not very aggressive as far as elderly patients are concerned. And some patients who have a low threshold for hypoglycemia, for such patients also, I give them a margin of probably their post-prandial blood sugar should be around 200 and fasting blood sugars probably around 130 to 140. I give them. But for most young patients who have to be complication free for the next 20 or 30 years, I think we have to be very aggressive with the blood sugar management. Otherwise, they will end up with all sorts of microvascular and macrovascular complications. In pregnancy also, my threshold remains low because we have to think about the fetal complications also. But for most patients who are elderly with renal failure, with hepatic impairment, and those who have hypoglycemia, unawareness for some reasons, probably because of autonomic neuropathy, I have a higher, I am a little lax with blood sugar control, and probably they can have a higher HbA1c values. So that they, because such patients who develop hypoglycemia frequently, they will discontinue your treatment. So to make the patient more compliant, you have to have a little relaxed treatment for such patients. So elderly patients and patients who have a lot of comorbidities, it's probably better to have a lax control of blood sugar.
Thank you. Thank you. Dr. Jayalakshmi, just one question to you. This was specifically put by our secretary, Dr. Suresh Kumar. This is basically on the role of RSSDI in promoting the diabetes awareness among the practitioners, especially at the primary care level. Diabetes is still a disease which has to be managed in a better way at the primary care level. And I always tell the students that it's not a disease which has to be treated in the super specialty hospitals. It's something which has to be taken care of at the primary care level. So is there anything an organization of RSSDI can do to improve it? Or are you satisfied with the amount of exposure that the primary care practitioners are getting? Since you are at Kochi, you might be able to get a lot of CMEs, but there are a lot of primary care practitioners and even the family physicians who are staying away from the metros, who might not be getting that access to the CMEs which we are conducting. Even though we are having the webinars, most of them are not able to attend. Many of them do not know that there is an organization called RSSDI. So your opinion on that?
Prashant, I'm audible, right?
Yeah, very much.
Yeah, thank you so much for the question. At least I think I would like to take this opportunity to congratulate the new members of the RSSDI, because they have started a YouTube channel, which I think I have subscribed to, though I have not seen any videos pertaining to any topic as of now. But I think that could be a very good reach for the primary care physicians. And I think those of them who are already RSSDI members, almost monthly we have, I think, CMEs, online CMEs that have been conducted, and they are there on the YouTube also. So whenever we are free, we can go and update ourselves with it. There are a number of CMEs that was happening in Kochi, and COVID has brought us into a sort of an inertia. So now going for an offline CME has become a bit of a difficult task. Online, yeah, in the comforts of the home, it is still possible. But I think RSS is doing fantastically, in the sense that they have, if we have this YouTube, we can use it to explain the complications and the new pathophysiology. What you did, it was a brilliant thing about the new modalities of pathophysiology that has been brought from the older, like from the trimerate to the 13 octet, and after that to the 12 causes of pathophysiology. I think if we have a forum or a YouTube where anybody can reach in their free hours, they can update themselves.
Thank you, Dr. Jayalakshmi. I think we have crossed the time. We started a little bit late, and so we had to end a little bit late also. We will have a final say from Dr. Balakrishnan sir on what are your takes from this meeting, or what are the things which you want to communicate to the audience on the management of diabetes? A few important points.
Yeah, thank you, Prashant, for this question. Before that, I want to tell that we are facing a peculiar scenario of diabetes management in our state. So what I want to highlight is that there is a gross divide between the government sector and private sector. And in government sector, and then certain subset of the patient, none of these advances in the pathophysiological process and modification of the diabetic drug is not available to a sector. And if you, in this discussion itself, if you look into Dr. Srinath's session, he's at the liberty to start an basal things at the outset. But in most of the patient who is in the other aspect, they are getting the same dose of glimepiride, metformin, and whether the patient's diabetes is newly onset or is 20 years, 25 years, whatever it is, that is one of. So we do not have an exact guidelines in our state what to start and what to use, and many of the people in our state is deprived of these newer molecules and newer moiety and newer intervention. So how we are going to improve the glycemic status and with this gross divide, and that is one concern which I want to raise to this point. Then another is the treatment and the other things, as you have rightly pointed out, the social media intervention, and every neighbor and every person, everybody who has got a mobile and WhatsApp is interfering with our treatment, and a subset of the patient is carried away by these comments and these postings and these suggestions. And even I came across a few patients who keep some particular leaf in the chapels for 1 week, and somebody told that if you keep this particular plant and the leaves in the chapel, your blood sugar will come down. And there are many other things who takes some. I probably all these learned people will be knowing what is happening in the. We know all the international guidelines, AD guidelines, CSAD guidelines, and we discuss in seminar forum. And all the learned participant of this forum know what is the diabetic, the complaints of the patient in our country. Another pitfall I came across nowadays is now many of these people who is going to the overseas, to Ireland, Australia, or the Gulf country for various reasons. Many of the houses in our in the locality has been got closed, and these people are going to the UK, USA, or in the Gulf country, and they came to our clinic or in the hospital, get a prescription of 6 months medicines, and they go on taking the 6 months medicine, and after the medicine exhausted, now neighbor is going to the Gulf country, and they stop the medicine, and they came back after 1 year, and they fresh start with some drug, and that is happening in the interfering with our diabetic management. And this is a real scenario. I don't know what about the southern part of your area, what is it is going to happening and all know. And another issue that all the patients who are going to a public sector or other sector, they give with the 40 unit insulin, and with all that complications and this other thing that is happening. And another problem, a majority of the elderly people, geriatric people at the age of 78 to 85 years, they are staying in a home. There is no children, there is no neighbors, there is no caretakers, and we prescribe an insulin, either a basal insulin or inertia, therapeutic inertia from the part of doctors, fear of hypoglycemia, fear of complications, and the cost effectiveness. If you add some newer insulin or drugs, the patient may go to the other place and they may disappear, they may stop the medication. So again, they are cutting the same medicine. And I saw so many people, diabetic patient who has got a blood sugar of 290 fasting. When after some injection medicine has come down to 250 fasting blood sugar, 40 reduction, they are happy. They are very, very happy with that management, and they continue. So there is another issue with the therapeutic inertia, and from the part of the patients as well as from the doctors. I think beyond the science and other sophisticated technologies and other things, the real scenario of the diabetes patients in our state is very, very pathetic, and we need to address all those issues.
Thank you, sir. Again, what you said was exactly right. We can talk any number of technological developments, drug developments with our PowerPoint slides, but the real scenario in the with the common man is different. I think that is the responsibility for RSSDI, isn't it, Suresh sir?
Exactly. You said it. Anyway, I think it is time for us to wind up. Every good thing has to come to an end. Now we are also coming to an end of this particular program. I thank profusely Dr. Prashant Shankar and all the other panelists for wonderful deliberations and very informative and detailed discussions about what's actually happening at the ground level, zero level. And I think we'll be able to sort of carry forward with this sort of activities in future as well. And I expect all those who have participated here to like invite more of your colleagues to join our academic activities here again in future too. So with this few words, I think probably I'll conclude this academic session here. And thank you all, and the meeting will be adjourned for the next session. After this academic meeting, we have an organizational meeting for 15 minutes. So I would request all those who are not part of the organization, that is not part of a governing council, to leave the meeting and let us deliberate something on the academic aspect as well. And thank you. Good night, all those here. Vinod, Baleshan sir,
Sure,
Vidhi,
thank you for
Nileshmi madam, everybody. Thank you. Thanks a lot.
Bye.
Thank you. Thank you all.
Yeah, Chandri madam, take over, please.
Thank you.
okay, thank you.